especially Dr. Jayanto and his team, uh, KSD Dental College. So we really congratulate for selecting this type of topic. As you introduced, Dr. Shubhalakshmi ma'am, it requires really a strong base, and we need to understand the salivary gland, the basics. Then only we can move into that the pathology portion. So I hope that definitely the every one of us, those who have joined here, will be benefited with this. And of course, the beautiful speaker, she's very excellent and eminent personality, Dr. Punya ma'am. And also, uh, the moderation also is going to be done by the equally the same personality, Dr. Subbalakshmi ma'am. So, my many congratulations. Definitely that we are going to have a fruitful sessions today. And I appreciate Dr. Jayanto for doing these type of academic orient activities, and so that our fraternity will be benefited. Thank you, ma'am.
Thank you, sir. Just a few points about the technical aspects of this webinar. Most of the participants have been muted by default. So if you do have any questions during the course of the session, you may post it in the tools section of your window, where there will be a Q&A box. Please post your questions over there. We will be addressing the questions at the end of the sessions. And if you have any other doubts regarding the any other questions, you may post it in the in-chat question box that is present on your screen. Moreover, we will be recording this session and transcribing it, so this is for everyone's knowledge. Moving on, I would like to now introduce our speaker for today, and it is my absolute pride and honor to do that. Professor Dr. Punya Angadi Rao is a distinguished oral pathologist with over 20 years of academic, clinical, and research experience. She holds a BDS degree in 2001 and MDS in oral pathology in 2005, with distinction and first rank from RGUHS and DNB in 2008 in oral pathology from SDM College of Dental Sciences, Dharwad. She further earned a PhD in oral pathology with a focus on oral precancer and cancer from KLE Academy of Higher Education and Research, where she currently serves as a Deputy Director for Research for the university. In addition to her core training, she holds a postgraduate diploma in bioethics and a fellowship in forensic odontology, reflecting her multidisciplinary expertise. Dr. Angadi's research contributions span over four critical areas: oral cancer, OPMDs, especially OSMF, artificial intelligence and early cancer diagnosis, and forensic odontology. A prolific academician, she has authored over 135 publications in indexed, peer-reviewed international journals and contributed to 5 textbook chapters. She has received multiple national and international research grants of over 3 crores in Indian rupees and holds 35 patents and has mentored numerous MDS and PhD scholars. She has been honored with several accolades, including the Best Teacher, Young Scientist Award, Best Scientist Award, Outstanding Research Publication Award, Best Scientific Paper Award, etc. A sought-after speaker, she has delivered numerous keynote lectures and conducted workshops at prestigious national and international platforms. She was the organizing secretary for the 30th National Conference of IAOMP held in Belgaum and is currently an executive committee member and associate editor for the Journal of Oral and Maxillofacial Pathology. Her career reflects a rare combination of academic excellence, research innovation, and commitment to advancing in the field of oral pathology. We are truly honored to have you on board with us, ma'am.
Thank you so much for that introduction, Dr. Subbalakshmi. And at the outset, I would like to thank the Dr. Jayanta for inviting me to conduct this webinar series. Dr. Shubhalakshmi, who was always there to answer all the queries, and the entire department, and all the participants who have joined in. I hope I can get through you and present this seminar to your satisfaction here. Shall we begin?
Yes, ma'am. Over to you, ma'am, please.
Yeah, I'll just share my screen. I need to be allowed to screen share.
You're not being able to share your screen, ma'am.
I'll try again.
Yeah.
Is the screen visible?
Yes, ma'am. Yes.
Shall I begin then?
Please, ma'am.
Okay, and my voice is audible?
Absolutely.
Okay. Good morning to all. So today's session will be on foundations, the development of salivary glands, before we dive into the second and the third sessions where we are going to actually look into the salivary gland tumors. But before we begin with the foundations, let us take an overview of salivary gland tumors and why we feel that salivary gland tumors are difficult to diagnose. First and foremost, they are rare tumors, so there is limited exposure to, as a postgraduate, maybe even as a faculty, the exposure to the number of salivary gland tumors that you get is so that doesn't actually give you the confidence to do the diagnosis in a very precise manner. Second thing, they have varied origins, in the sense they have luminal, abdominal. We will be making it clear subsequently. So that also makes them and they are very histologically heterogeneous. There is no uniform patterns that you see across the spectrum of salivary gland tumors. So there is a lot of overlap between the tumors to categorize them into specific categories, and they are known for their morphologic diversity. So they are very diverse tumors. For example, just taking a simple pleomorphic adenoma, which is considered to be the most commonest salivary gland tumor, there is so much of diversity that the one pleomorphic adenoma doesn't resemble the second one. So there have been so many which I have seen in my career, and not a single one resembles the other one. So morphologic diversity is a hallmark of salivary gland tumors. So that also makes them difficult to diagnose. And they have a deceptive appearance. The malignant tumors do not have a clear-cut distinction in terms of pleomorphism. Sorry, with regards to pleomorphism and atypia, as you see in non-orogenic tumors. So if you have pleomorphism, you have atypia, you have hyperchromatism, you can clearly say that it's a malignant tumor. It doesn't happen so for some, because even the malignant tumors may have uniform appearances. The case in point is adenoid cystic carcinoma. So there you need to actually clinically correlate and search for different avenues, process or infiltration. So there is no clear-cut do give a deceptively benign appearance. So these are some of the reasons why usually salivary gland tumors are felt difficult, especially by the postgraduates. So salivary gland tumors, the global incidence is around 0.4 to 13.5 cases per 1 lakh population. About 0.3% of the all human tumors, so they are very rare. And 3 to 10% of course occur in the head and neck tumors, because salivary gland tumors are predominantly in the head and neck region. Again, the incidence of malignant and benign tumors varies. We'll be covering it later. The exact etiology is not known, but there are various points that have been. It could be because of viruses. It could be because of exposure to radiation therapy, chemical exposure, hormonal changes, especially related to androgen receptor positive tumors. Then you have autoimmunity could be one of the causes, or it could be because of mutation in tumor suppressors or oncogenes. So there is no clear-cut definitive etiological factor as you see in a non-orogenic tumor. So the general features usually seen in elder age groups. So we are of late seeing a lot of tumors occurring even in younger age group of 40 to 50 years, but traditionally they are believed to occur in elder age group, that is 5th to 7th decade, and females are predominantly. So the origin could be either from the epithelial component or the mesenchymal component of the salivary gland tumor. So salivary gland has got parenchyma and stroma, but majority, 80 to 90% usually are from parenchymal origin or epithelial origin, and the nature can vary from benign to malignant. So 75% are benign. Malignant usually forms a very small percentage. It's about 20 to 25%, but they are important to be diagnosed so that they can be treated in a apt way. So the clinical presentation of the benign tumors is usually in the form of asymptomatic slow growth. But if you find that there is any rapid growth, there is pain, there is ulceration, and there is facial palsy, especially associated with parotid tumors, you have to suspect it to be a malignant salivary gland tumor, or it is happening in a benign tumor which is present for a long static and suddenly shows rapid growth, so you have to think of malignant transformation. So clinical correlation in salivary gland tumors also plays a very important role to identify whether it is a benign. So over the years, the classification and the new tumors that have been entered into the WHO classification has been vast. So from 1972 to 2022, there are a lot of additions which have happened, and there are a lot of changes with regards to the behavior. They have been classified into benign and malignant. So if you see the latest WHO 2022 classification, currently under the benign epithelial tumors, we have 15 entities, and under the malignant salivary gland tumors, we have 21. But today I will not be here to let you know what are the entities. We are not going to memorize what are the entities. We are not going to try to categorize the entities based upon the names. What we are going to do is we are going to look into a slide and approach a slide as an oral pathologist and try to analyze the slide and think about the diagnosis rather than memorizing it or going through the WHO list. So that's what we will be doing in this webinar series. Rather than giving you a rote about the WHO list, we will help you to approach. What I want to do is help you to approach a salivary gland and identify what is normal, what is reactive, what is neoplastic. So what will today's session do? So today's session will build your confidence in the normal histology and pattern recognition, and make you realize that why normal is the most important diagnosis. So if you know what is normal, definitely you can identify what is abnormal. So let's see the salivary glands. The salivary glands are categorized basically into major and minor salivary glands. Major salivary glands are present extraorally. They are paired glands. So we have three. You have the parotid gland, which is usually present here, and it opens in with the stenosis duct into the upper first molar intraorally. And the gland, which is in the floor of the mouth, and it is opening into the lingual fold, and you have your sublingual gland through the Wharton's duct, and then you have the sublingual gland which has the Bartholin's duct and the duct of Ravenous. So these are your major salivary glands. The majority of the saliva that is coming is from the parotid gland, which accounts to about 70 to 80% of the salivary secretions, followed by the submandibular gland. The sublingual and the minor salivary glands actually contribute a very minute amount of saliva secretion. So apart from the major salivary glands, you have the minor salivary glands. So the minor are located in the submucosa throughout the oral cavity, and they may be about 5,000 to 1,000, and they are named based upon the location. So if they are present in the labial mucosa, they are called as labial glands. If they are present in the palate, they are palatine. If they are present in the tongue, they are lingual glands. So you can see that most areas of the oral mucosa, you have the minor salivary glands, except for the gingiva and the anterior part of the hard palate. So if you find any salivary glands in the gingiva or the anterior part of the hard palate, it should be considered ectopic, because normal salivary glands are usually absent in these two locations. So you have a fine duct system in case of a major salivary glands, but you have a very abbreviated duct system in case of minor salivary glands. So the secretion from these salivary glands usually can be either serous, mucus, or mixed, and based on which they are also classified. So you have parotid gland is a purely serous gland. So you have predominantly serous secretion. The serous secretion is considered to be watery, and it is rich in enzymes and proteins. Then you have the submandibular gland, which is a mixed gland, but it's predominantly serous. So you have serous predominance here. And then you have the gland, also a mixed gland, but it's predominantly mucus. So the mucus secretion is a more viscid amount of carbohydrates. So the minor salivary glands, most of them are mucus. Remember, most of them are mucus. Few of them can be mixed, and only the purely serous minor salivary glands are seen in the circumvallate papillae, that is the von Ebner's gland. Okay, so it's important to know which of the tumors, which of are serous, mucus, and mixed, because then you will be able to identify them when you get it in your biopsy and in your slide. So location is important for diagnosis, because location narrows your diagnosis before you go for microscopy. So if 70% of the tumors, salivary gland tumors, are occurring in parotid gland, and then you have the minor salivary glands and a small percentage in the submandibular salivary gland. Sublingual salivary gland, extreme rare to get a salivary gland tumor, but if you get a salivary gland tumor in sublingual gland, it's more commonly a so malignancies are more common in sublingual salivary glands and minor salivary glands. Okay, so whereas parotid is and submandibular, the amount of benign compared to the malignant tumor. So if the minor salivary glands are considered, the common locations are usually the palate, lip, and the buccal mucosa. And occasionally you can have ectopic salivary glands intraosseously, especially in the posterior mandible. One location where you can get an intraosseous salivary gland tumor. So let's see the architectural organization. So basically, salivary gland is made up of stroma and it has got parenchyma. So stroma is mesenchyme, parenchyma is the epithelium. So the stroma is basically forming the capsule and that is extending in between the acini and the duct in the form of septae and dividing it into lobes and lobules. So the stroma will contain cells, it will have the collagen fibers, and it will have the blood vessels, nerves, and the arteries which supply to the epithelial component. So the epithelial component is made up of acini and ducts. So we'll see ahead what are the acini and ducts. So the acini can be again three types. You can have a serous acini, you can have a mucous acini, and you can have a serous demilune, which is a mixed acini. Apart from that, you have types of ducts. You have that based upon the size of the duct, you have the intercalated duct, striated duct, and the collecting duct. That's why they are also referred to as compound glands because they have an extensive duct system which is of varying caliber. So, so you have intercalated ducts, which are the smallest one, followed by the striated and the collecting duct. Apart from that, you have your myoepithelial cells, which can be seen associated with the acini and the intercalated duct. The striated basal cells and the collecting duct also has basal cells. Okay, we'll be seeing in detail subsequently. So this is the gross appearance of your salivary gland. So if you can see, there is a capsule which is extended in the parenchyma to divide it into lobes. Okay? And further, they will be divided into lobules. So if you see it histologically appearing, so this is your which is extending in between the stroma and dividing into lobes. So the larger components are referred to as lobes, and the lobes further are divided into small lobules. So the connective tissue septa extends in between to divide it into lobes and lobules. Okay, so these lobes and lobules are having your acini and duct. So the septa usually consists of the cellular matrix. So the cells of fibroblasts, and the component, there is some amount of extracellular matrix in the sense of ground substance. Apart from that, you have a lot of these blood vessels, which are the supporting structures, nerves, and lymphatics, which act as a supporting structure. But definitely, these could also give rise to tumors. You can have about 10% of mesenchymal tumors also arising in the cell location. So you can blood vessels, you can have arterioles, arteries, and you have your veins, have ducts, the intra-lobular ducts, that is the septae which is dividing the two lobules. You have this space, have the larger ducts here, that is the intralobular ducts, and lymphatics can also be seen. These are your nerve tissue. So this is a vein, this is a nerve tissue, these are your ducts, larger ducts, and arterioles. And they have a vesicle which is placed basally, and they usually take up a very dark purple. So why they take up this dark purple stain is because the secretion of the serous acini is rich in proteins and enzymes, and so it is a synthesizing cell. It's a protein synthesizing cell, and the organelle that is responsible for protein synthesis is the rough endoplasmic reticulum. So you have a lot of rough endoplasmic reticulum within the cytoplasm, which is seen in the basal third. And then you have these pink zymogen granules, which are seen towards the apical third. So you have pink and you have blue, and together they appear purple. So that's the reason why they appear purple and dark. And this darkness of the acini usually varies depending upon the activity of the acini. So I'll show you a slide subsequently where the activity The activity is less, it doesn't take up that much of a dark state. So serous acini appear dark. Okay, so they appear dark, they appear purple. Then you have your mucous acini, and they are described as tubular or elongated. Okay, and the serous acini usually have a regular lumen, whereas these have irregular and a larger lumen. Here also the cells are pyramidal, but they appear to be bloated, and you have the present which is pushing the nucleus to the periphery, so they appear to be flat. So if you see a mucous acini, what you see is a pale, foamy or a bubbly appearing cell. So that will that will be the apt description for a appears to be pale. Pick up the stain because the mucin is usually lost during processing. And then you have the mixed acini, which are also referred to as the cirrus demilunes of see. So they appear to be mucous acini, which is capped by a crescent of or a half part of your serous acini. Okay, so it's a mucous acini which is capped by a serous acini, so mixed acini. So the mucus secretion viscid and this in carbohydrates. So the organelle that is most prominently seen when you see an electron microscope of a mucous acini will be Golgi apparatus, whereas in case of serous acini, it's more of rough endoplasmic reticulum. Okay, so these are your serous acini. You can see the zymogen granules very clearly here. So they appear to be acidophilic or eosinophilic, and then you have a lot of rough endoplasmic reticulum. Together, they give the purple hue that is very characteristic of a serous acini. And these are your mucous acini. You can see the nuclei. Nuclei here, again, both are in the basal third, but here it is spherical. But if you see the nuclei of the mucus, flattened, and they are usually at the periphery. Okay, and they have a irregular lumen. They appear foamy. So that's how you identify the mucous acini. And these are your mixed acini. You have your mucous acini, which is capped by a crescent or a half moon of a serous acini. Okay, so if you remember, the mixed glands are the submandibular and the sublingual salivary glands, and the purely serous salivary gland is the parotid, which predominantly whatever pictures you're seeing here, this is a submandibular gland, which will have predominantly 70 to 80% of serous acini, and then you have some amount of mucous acini, and you acini. And if you go for a sublingual gland, as you can see here, it's a predominantly mucous gland. So you have predominantly mucous acini. Along with that, you may have some mixed acini along with it. So these are how you will be seeing it if you take a biopsy of the salivary gland. So this is your serous acini appearing spherical, mucous acini appearing tubular, and your mixed acini with of serous acini. Okay. So this is how you see the variation in staining depending upon the activity, the amount of proteins that are being produced by the serous acini. So you can see here they are darkly stained, whereas in the rest of the areas they are not much. So the activity determines the darkness of the staining. But in general, what you need to remember, serous acini appear pale. So the next component we have is the ducts. So you have the first duct is the intercalated duct. And then you have the striated duct and the collecting duct. So they are not mere conduits, they're actually making changes in the salivary secretion. So the basic secretion is coming out to the acini, they go to the canaliculi and then enter into the intercalated duct. The intercalated duct adds some enzymes, and the most important and the initial coming out to the acini is usually isotonic, but as it comes to the striated duct, this has a very important role. It makes the saliva hypotonic. So hypotonic saliva is because of the reabsorption of the sodium and chloride and addition of potassium and bicarbonate, which is done by the striated duct. So the striated ducts appear striated is because of this basal striation. So the basal enfoldings which are filled with mitochondria. So the mitochondria is the one which is providing the energy for bringing about this electrolyte exchange. And subsequently, it goes into the collecting duct and opens into the oral cavity and comes into the oral cavity. So these are your ducts. They are classified based on the location into interlobular, and then you have intralobular. So if they are within the lobule, they are the small caliber ducts. So you have your intercalated duct and the striated duct within the lobule. So they are referred to as intralobular ducts. Whereas if they are present between the two lobules, they are interlobular and they're usually the collecting ducts. They can also be classified based on the caliber into intercalated, that is the smallest, followed by striated, and then you have the collecting ducts. So the intercalated ducts are very difficult to identify, especially in the parotid, barely discernible, and they are very inconspicuous. They tend to merge with the acini. But if you see them, they are lined by, this is an intercalated duct. Here also you can see an intercalated duct opening into the striated duct. Say they usually are spherical, centrally placed nucleus and a well-defined lumen here, and doesn't take up that purple stain that is very characteristic of a acini, but it does, it's very difficult to identify. An intercalated numerous in the parotid gland. Okay, so you have your duct here, which is opening into the striated duct. So these are your striated ducts. So the striated ducts are very striking. They are easy to identify. They appear, typically they have been used with the adjective as pink necklaces. So they appear like pink, larger lumens, they are larger in size. And if you see the cells, they are tall columnar. The cells which are lining are tall columnar with a centrally placed nucleus, and you have the presence of these basal striations, which are very evident in this particular slide. You can see the striations which are there, which is because of the basal enfoldings and the increased amount of mitochondria. So actually they resemble somewhat like oncocytic cells, which you see in Warthin's tumor as well as in striated duct adenoma. So these are your ducts, they are intralobular, and these are your striated. These are your striated ducts. Striated so the intercalated are more numerous in the parotid. The striated ducts are more. And then you have your ducts, which are larger caliber ducts, and also the collecting ducts open to the
Dr. Sangeeta Patil, if you could please turn your mic off. Thank you.
Okay, so these are the collecting ducts, and the lining of the collecting ducts usually varies. So it could be cuboidal, it could be stratified, pseudostratified goblet cells, and as it comes closer to the oral cavity, it can be stratified squamous as well. So you can see here, this is the pseudostratified epithelium. Then you have your cuboidal, and this is as it comes closer to the oral epithelium. So the collecting duct, or the excretory duct lining is usually this lining is showing your stratified simple cuboidal epithelium. This is showing the pseudostratified ciliated with goblet cells. Varies depending upon the location. Towards the salivary glands, it's more of ciliated and cuboidal. As it goes towards the oral cavity, it becomes more striated and merges with that of the oral epithelium. So these are the different types of ducts that you're going to see in the oral cavity in the salivary glands. Whereas for the minor salivary glands, I already mentioned, you have an extensive ductal system in the major salivary glands, but in the minor salivary glands, the ductal system is very abbreviated. So you have some intercalated ducts, and then you have the excretory ducts, very less of striated duct. And there was a question that Dr. Subbalakshmi said that why there are less striated ducts in minor salivary glands, because their function is not needed in minor salivary glands. Minor salivary glands are contributing to very less amount of saliva, and their role is basically to make the saliva hypotonic, whereas minor salivary gland saliva is basically used for lubrication and used for as a immunity. So they are the ones which are producing the IgA, and they are responsible for the local immunity. So striated ducts actually do not have a role here. They have a very abbreviated duct, usually open to the surface. So this is a minor salivary gland. It's a mixed minor salivary gland. So you can see some intercalated ducts here. Very rarely you can see striated ducts in minor salivary glands. So why we need to know about the ducts and the acini, and how they stain, how do they look, because they are the ones which are going to predict the tumor morphology subsequently. So I already told serous cells look dark. So a tumor which is arising from the serous cell, like the acinic, it will look more cellular and it appears dark. What my teachers used to say is, if you see a purple hue and sheets of purple acini on the slide, think of acinic cell carcinoma. So it actually gives you a clue of what sort of a tumor you are dealing with. And if you have mucus cells in a tumor, it usually appears pale and it is cystic. And sites of striated duct associated tumors, they usually appear more pink. So these will give you a clue as to what the origin could be. And the ducts explain the diversity that you see in salivary gland tumors, like tubular appearance in canaliculair adenoma, the cribriform appearance in adenoid cystic carcinoma, the papillary projections and the cystic appearance in both in tumor, the ductal pattern that you see in epithelial myoepithelial carcinoma as well as in parotid pleomorphic adenoma, and the solid sheets that you see in basal cell adenoma. So the ducts and acini are those which are determining how the tumors are going to appear. So the next component that we are going to discuss is the myoepithelial cells. The myoepithelial cells are not just present there, they are considered to be the silent architects which are dictating pathology, and they may be barely discernible in a HND section. And usually you can only see the nucleus. So this is the myoepithelial cell which is usually present between the basal lamina and the basal membrane of the so usually you can only see a nucleus in HND sections, and it's very difficult to identify myoepithelial cells in HND stain sections. But they are usually associated with the intercalated ducts. So the location is they are first of all, they are present between the basement membrane and the basal lamina, and they are usually associated with and the intercalated duct. They are not seen associated with the striated or the excretory duct. So the myoepithelial cells may be associated with acini regardless of the type of acini. So if it's a serous acini, or it is a mucus acini, or it is a mixed acini, you have myoepithelial cells seen associated with it. So it will have a central body and numerous extensions, and so it appears as if it is cupping or it is hugging the acini like a bar. So they usually use the term basket cell for it, and this appearance is not very prominent in case of the ducts. In the ducts, usually they appear just as a fusiform or a spindle-shaped cell. So this is your myoepithelial cell. It has a cell body and several extensions. So it is thought it is a the name myoepithelial cell suggests that it is origin is epithelium, but it has the property of a muscle cell. So it is called as a myoepithelial cell, but it is a cell but has the property of muscle cell because it contains actin and myosin tonofilaments. So it extends on the acini, and it usually gives the appearance of an octopus sitting on a rock appearance. So you have a cell body and several extensions, which gives an octopus sitting on a rock appearance. So you are very difficult to identify in HND stain sections. So you have to use special stains like the PTA stain, that is the phosphotastic acid hematoxylin, which will help you to identify, or you have to use immunohistochemistry like alpha SMA or actin for identifying epithelial cells. So having said that, the myoepithelial cells are the key to the mixed pattern and the diagnostic confusion that you are seeing in the salivary gland tumors. So they are the masters of disguise. They are usually referred to as masqueraders, and they are responsible for 80% of the confusion that you are seeing in salivary pathology. So myoepithelial cells can make benign tumors look malignant and malignant tumors look benign. So it is a cell that you need to look diagnosing salivary gland tumors. So because they can take various forms when they are in the when they are the part of the tumor, they can appear spindle, they can appear plasmacytoid, they appear clear or void. They can also undergo oncocytic metaplasia, they can undergo squamous metaplasia, they may appear sebaceous or they may appear epithelioid. So they can take various forms, not only the epithelial components, but they can also give rise to stromal components, like they can give rise to myxoid areas, cartilaginous areas, lipomatous areas, immunization, as well as osteoids. So this, underscores how myoepithelial cell can actually change its form in multiple ways. And this is one of the cells that is responsible for the morphologic diversity and the heterogeneity, which is a characteristic feature of salivary gland. Apart from these components, like you have the stroma, you have the parenchyma, that is of acinine ducts and the myoepithelial cells, you can also find some amount of inflammation the normal component in salivary glands. That is around the blood vessels and occasionally around the ducts. So it will be perivascular or periductal. So it should not worry you if it is a small amount of inflammation. So this is also showing the perivascular uh, inflammation here. And then you have, sometimes it may also be present throughout the gland. As long as it is not causing any disturbance to the architecture of the gland, the inflammation may not worry you, and it could be a common component because the stromal component does contain some inflammatory cells as a defense mechanism. So you have macrophages, you have lymphocytes, plasma cells, mast cells as a component of salivary glands. You also have adipose tissue. It may not be more, especially more prominent in the parotid glands. So you have adipose tissue, which may be a normal component that is present within the salivary gland. As I said, the parotid gland starts developing around the 6 to, and once it develops, the capsulation or the capsule usually forms at the last stage. And when there is the development of the parotid gland happening, there is concomitantly the mandible developing close proximity. You have the cervical lymph nodes, which are also developing in the close proximity. And it is said that because the capsule forms last, inclusions of the lymph nodes which get included into the parotid gland. So many a times you can find these intraparotid lymph nodes within the parotid gland, which is considered to be normal. And vice versa, you can have some salivary gland inclusions within the lymph nodes also. So the cervical lymph nodes, when we are analyzing, many of the times we have observed when we are doing the R&D evaluation of the lymph nodes, we have found instances salivary glands within the lymph node, and they could be, and we also have a case, I think I'll be sharing it subsequently, where we got a walk-in tumor developing in the cervical lymph node. So that is that could be one of the source. You can have salivary gland inclusions in the lymph nodes, or you can have lymph nodes within the parotid salivary gland. This is basically because of the development and the encapsulation which occurs at a later stage entrapment. Similarly, during the development of the submandibular and the parotid gland, the mandible is also developing in the similar area, and many a times you can find that some inclusions may get into the mandible during the development, and this is more common in the posterior mandible, and we usually refer to it as a Staphnese bone cavity. So Staphnese bone cavity is a cystic radiolucency which is usually identified incidentally, which is below the inferior now canal, and it appears to be a radiolucency with a radiosclerotic border, and often mistaken as a cyst by the surgeons, but it's nothing but a developmental anomaly which contains salivary gland tissue. But it could serve as a source for development of salivary gland tumors. Another finding that you can get is you can find presence of sebaceous metaplasia that could also be present in the salivary glands. So there are certain age changes that you can see in older age group. If you see the salivary glands for older age group, you can see that there is increased fatty degeneration, which is very common in elderly age group. So I showed you the adipose tissue that you normally expect in the salivary gland, but with age you can see that there is increased amount of fatty degeneration, which may consequently lead to decreased secretion and xerostomia, because parotid is providing the maximum amount of saliva to the oral cavity. So there may be fatty degeneration as a age change, and also you can find oncocytic metaplasia. So this was the entire lobule. You can see that is changed to oncocytes. So oncocytes are round to ovoid cells which appear to have intense eosinophilic granular cytoplasm with a centrally placed nuclei, which can be pycnotic or it can be well defined, but usually it will be vesicular. Okay, so these are the oncocytic change. It's considered to be a change, but it could be a source for development of oncocytoma or oncocytic carcinoma subsequently. This is showing, this picture is showing the crescent, only the demilune is showing oncocytic change. So you have to look for this, and when you're looking into the slide, look for the oncocytic change. So the oncocytes usually appear to be dark pink in color because of the eosinophilic granular cytoplasm, which is because of the abundant amount of mitochondria present within them. Another change that you can see as the age related change is atrophy and ductal hyperplasia. So you can see these are your lobules which are having your well-defined acini, but you see this particular lobule, there are no acini present here. So the acini have disappeared. So there is acinar atrophy, there is loss of acini, and the ducts are still remaining behind. The ducts are more resistant to changes, including especially if you see post-radiation, the acini will be reduced, completely destroyed, but the ducts still remain. So the ducts will undergo hyperplasia. If you see a hypo view of the same, you can see here the acini are completely replaced. It could be secondary to inflammation, and you have your ducts which are hyperplasia, in the sense they are more in number. They can also undergo squamous metaplasia. Many a time, because of the squamous, they can undergo squamous metaplasia. I think it is in the next. Sorry, it's not there. So they can undergo squamous metaplasia. You can see here the luminization will be lost, and they will be appearing like small nests and islands of squamous islands. Okay, so these are the 8 changes that you see in the saliva. You should not think it to be abnormality, which is a normal component. So special stains that you can use for the salivary glands, the most common one is the PAS. So the periodic shift technique, which stains the serous acini. So the serous acini usually take up an intense PAS positivity. It also identifies the mucous acini. So you can see beautifully shown in the PAS stain, the mucous acini and the serous acini showing positivity for PAS. And then you have the mucicarmin stain, which is a general purpose stain for mucous acini. So if you have a suspicion for a mucoepidermoid carcinoma in a predominantly intermediate or a high-grade tumor, we always go for a general purpose mucin stain, that is mucicarmin, and it's very sensitive to identify the presence of mucus cells. So they usually appear to be pale pink in color. So this is mucicarmin stain highlighting the mucus acini. Apart from that, you have IHC markers. There are a lot of IHC markers which are present, but I would like to underscore here, IHC markers should not be taken as a first implication whenever you're doing any salivary gland tumor diagnosis. They are going to confuse you more, because they are already present in the normal duct as well as the myoepithelium. If you are using IHC, it should be to rule out the other tumors, not to confirm salivary gland tumors. We will be discussing this subsequently anyway in the next next webinar, but it's a caution for the PGs that don't jump for IHC. IHC does not confirm, it will confuse you more. Okay, so IHC should be only a secondary tool. The morphology, the patterns are things that you need to look for to come for a diagnosis. So the ductal cells are usually positive for the low molecular weight cytokeratins and epithelial membrane antigen and CEA, whereas the myepithelial cells are positive for a whole lot of markers, alpha SMA, calponin, high molecular weight cytokeratins like CK14, S100, Carl-Desmond, etc. Some pictures here. This is the epithelial membrane antigen positivity in the ducts. This is a pan-cytokeratin, so it has taken positivity for entire parenchymal component. You have the alpha SMA, P63, and the calponin, which are predominantly marking the myoepithelial cells. So let's go to the development of salivary gland. Why development? Knowing development is important, because the tumors could be either arrested in the development or exaggerated development, and that's how tumors usually develop. So parotid glands, as I already mentioned, develop around 4 to 6 weeks, the submandibular around 6 weeks, and the sublingual and the minor salivary glands 8 to 12 weeks. And the salivary gland development is very much reminiscent of your odontogenesis. So you have the oral epithelium, which is proliferating into the underlying connective tissue, or the mesenchyme in the form of a bud. And the mesenchyme is actually actively participating here to, influence the overlying epithelium to proliferate into the underlying connective tissue. And once it forms this bud, it goes on proliferate. Then it undergoes a branching morphogenesis. So you can see here the branches that are coming out. So this branching morphogenesis continues for a long time, and then subsequently you have the canalicular development of the canalization of the ducts, and this begins at the proximal or the distal end and then comes to the proximal ends, and then it divides them into ducts. Okay, and you can see that the mesenchyme is playing a very active role throughout. So the mesenchyme, after the entire acini and duct morphogenesis has happened and differentiation has happened, this becomes the capsule and also becomes the connective tissue septa. And as I mentioned, the parotid encapsulation is takes quite a long time, and that's the reason why you can have some nodes as well as cervical lymph nodes because of the close proximity of its development. Okay, so these are some pictures of the salivary gland development. I've taken it from 10K, while rest of all the, unless mentioned, all the pictures are from the departmental archives. Okay, so these are the, you can see the branching morphogenesis happening here, and also the and if it starts from the distal end and then progresses to the acini, so these will form your ducts and then you have your acini. So typically they are usually referred to as a bunch of grape appearance. So it starts from the excretory duct and goes on till the acini, and the acini will be the grapes and the ducts will form the branch or the bunch. So salivary gland development is important to know because it is a conceptual framework for the tumor patterns that you're going to see. So there is a lot of epithelial mesenchymal interaction. There is a bidirectional differentiation. I already told tumors may mimic arrested or exaggerated development. So they form the basis for the classification whether they are normal, reactive, or neoplastic. So going on to histogenesis and morphogenesis of salivary gland tumors, in order to understand the histogenesis and morphogenesis, we use a concept which is referred to as the ducto-acinar unit. So the ducto-acinar unit is basically composed of the acinus with the myoepithelial. You have the intercalated duct with the myoepithelial cell here. Then you have your striated duct, which has the basal cells. You have the excretory duct, which has again the basal cells. Okay, so these ducto-acinar unit again is classified into two types of cells. You have the luminal cells and you have the abluminal cells. And the combination of the luminal and abluminal is what is defining the morphology of the tumor. So the cells which are close to the lumen. So this is your lumen. It starts from the intercellular canaliculi. You have the lumen of the acini, goes on to the lumen of all the ducts. So those which are facing towards the lumen are called as the luminal cells. So the luminal cells will be your acinar cells, the intercalated duct cells, the striated duct cells, and the excretory duct cells. Abluminal are away from the lumen. So you have the myoepithelial cells, here, the basal cells of the striated duct, and the basal cells of the excretory duct, which will be your abluminal cells. So you have luminal and you have abluminal. I hope it is clear here. So there are various theories for histogenesis taking into consideration this ducto-acinar unit. The earliest was given by Batsaki, which said for the basal reserve cell theory. According to this, the basal cells of the intercalated duct, so these are your acini, this is striated, and this is your excretory duct. So the basal cells of the excretory duct and the intercalated duct cells are the reserve cells, and they are the ones which are giving rise to all the other cells and the morphology of and various other tumors. But second theory, which calls it as a pluripotent unicellular reserve cell theory, which says that only the basal cells of the excretory ducts have the pluripotentiality to differentiate into all other types of tumors as well as all other types of cells. The third theory is the semi-pluripotent bicellular reserve theory, where it says that the basal cells of the excretory duct and the luminal cells of the intercalated duct, both of them have the pluripotent. They can act as origins for all the tumors. The most accepted theory currently is the multicellular theory. According to this theory, the luminal and the abluminal, that is all cells, that is the acinar cells, the intercalated duct cells, the myoepithelial cells, the basal cells, any of them can actually proliferate, and they can all bring about different combinations and bring about the tumorogenesis of salivary gland tumors. So you should remember that there's a lot happening here. There are a lot of cells which are actually working together. So mixed patterns in a salivary gland tumor is the rule. So what do we get when you are using this ducto-acinar unit differentiation? So you have three pathways that usually are associated with tumorogenesis. That is, the tumors could arise from either the ductal or the luminal cells or the acinar cells with the myoepithelial and basal cells. So all of them are proliferating, or it could be only tumors from the luminal cells. So the luminal cells could be ductal and the acinar cells, or it could be tumors only from the abluminal cells, that is from the myoepithelial cells of the basal cells. So any of these three combinations can happen. So there is more than actually participating. So mixed patterns in a salivary gland tumor is not an exception, it's a rule. Okay, so that's something you need to remember. And again, the classification of the salivary gland tumors varies depending upon whether there is matrix formation, whether there is form. So it could be only proliferation of the luminal cells, or it could be luminal with abluminal without extracellular matrix. It could be proliferation of both luminal and abluminal with extracellular matrix production. Extracellular matrix here could be what you see in pleomorphic adenoma. You have these myxoid areas, the hyalinized areas. What you see in basal cell adenoma, the abundant amount of basal lamina that is formed. What you see in adenoid cystic carcinoma, the abundant amount of mucoid that you see in the cribriform pattern. So the extracellular matrix means that here. So if you have matrix or you don't have matrix, based on that you can classify the salivary gland tumors. Okay, so then it could also be only from the abluminal cells without extracellular matrix and with extracellular matrix. So, the example for a without extracellular matrix could be a myoepithelioma, where you do not have anything other than proliferation of myoepithelial cells. Whereas example with extracellular matrix could be your basal cell adenoma, which has abundant amount of extracellular matrix which is deposited. So based on this, there are a lot of there is a classification which can be we can have a diagnostic approach where you have to look for the morphology. You have to see whether it is from one cell or whether it is from two cell, and how the extracellular matrix is actually contributing. And there are various classifications which are given. We will be dealing with this in the subsequent webinars. But what I want you to focus here is the histogenesis is very complex. It is explained in a simple manner by using the ducto-acinar unit. That is, you have to understand that there are luminal and there are abluminal cells, and different combination of these luminal and abluminal cells are resulting in different types of tumors, and they are giving rise to different types of tumors. So you remember, mixed patterns are a rule, not exception. This is something you need to keep in mind when you are dealing with salivary gland tumors, because a single progenitor, as I already showed you, a myoepithelial cell can take up multiple lines of differentiation, and you can have a mixed morphology. Mixed does not mean malignant in case of salivary gland tumors, because if you had a mixed morphology, like if you had your spindle cells and you had your epithelial cells proliferating in a non-orogenic tumor, you would have thought it is a malignancy. Okay, so but it's not so in case of pleomorphic adenoma. The mixed morphology that you're getting is basically because of the inherent property of the cells which are actually participating it. So there is a lot of organized diversity which is already seen in the normal salivary gland. You have so much happening even in a normal salivary gland. You have so many different types of acini, duct cells. So this organized diversity is a component which is again reflected in the architectural diversity that you see in salivary gland tumors, and that is something you need to think it is normal, and then you need to interpret whether it could be a benign or a malignant tumor. So let's also see some non-neoplastic lesions that may mimic tumors before we actually go for the benign salivary gland tumors in the next session. So all of these usually present as swellings, and they may be histologically mistaken for tumors, especially by postgraduates. So the common ones which I will be discussing is sialadenosis, ductal ectasia, chronic sialidinitis, lymphoepithelial lesions, and retention cysts. So this is the case of ductal ectasia. You can see this is a parotid salivary gland, and you have nice lobules of salivary gland which are still intact, but you see these large dilated ducts everywhere. There's a lot of inflammation which is also seen, some amount of calcification here, but the thing that is striking here is these large dilated ducts, which could be considered to be a cystic neoplasm by postgraduates. So that could be something it may be confused with. So you can see these dilated ducts with incipient secretion within them. A lot of inflammation here. What you need to concentrate on is the lobular architecture is still maintained. Okay, so that will give you a clue that it is a reactive lesion. Whenever it is a neoplasia, be it a benign or a malignant neoplasia, the architecture is usually not maintained. So the architecture will be gone. Either it could be just a monotonous proliferation of the cells, or it may be destruction of the gland. Okay, so here if you see, there is a lot of acinar atrophy along with this ductal ectasia. Ductal ectasia is a dilated duct which is usually secondary to inflammation, and you will have these ducts which are seen in multiple areas. So this could be confused with the a mucoepidermoid carcinoma, low grade, or a papillary cyst adenocarcinoma, but you have to go through the components which are all which are usually present in a tumor. And also, most important key here is seeing at low power, identifying that the architecture is still maintained. Okay, so the architecture usually is not maintained if it is a neoplasia, especially if it is a malignant neoplasia. Okay, so here the clue is the maintenance of the architecture or the lobulation. So always start with low power. The high power is only to confirm your uh, uh, predictions or your diagnosis that you have, tentative diagnosis that you have come across. And also, when you see the ducts here, the ducts will be, the lining will be similar to a normal duct, whereas if you are suspecting a mucoepidermoid carcinoma, you will have the combination of epidermoid cells, you will have intercalated duct cells. So you need to look into all of that and rule out. But for this particular case, the most important thing that you need to recognize is the architectural maintenance. And then you have chronic silidinitis. Chronic silidinitis usually presents with swelling, and if it is a long-standing chronic silidinitis, it may also be presenting as a hard swelling, which may be mistaken for a salivary gland tumor if it is occurring in the submandibular or in the parotid gland. So what you see in chronic silidinitis is there is complete effacement of the acini. There is loss of acini, which are replaced by this dense inflammatory infiltrate, and then you have the ducts which are undergoing hyperplasia. But again, the lobular architecture still maintained. Okay, so the lobules are still intact, but if you see, there are no acini there. There is complete loss of acini. The ducts are undergoing hyperplasia. You can see they are dilated ducts. Let's see a hypo view of this. So you can see here, this is the normal salivary gland acini, which is still remaining. You can see the nice mucus acini here, and then you have the ducts. Just go to this particular lobule here. There is complete loss of acini. There is inflammatory infiltrate, one or two acini here. We'll go to a hypo to see that, and then you have these dilated ducts. Okay, so this is a normal acini, normal mucus acini which are seen in ducts, and all of that. This is the normal gland, but you see here, this is in chronic silidinitis. You can see that there is complete loss of the acini. You can see one or two acini still remaining here, but otherwise completely replaced. And you have these ducts which have undergone hyperplasia. The number of ducts have increased, and also they undergo metaplasia. And they become dilated. Okay, you can see these dilated ducts. They also undergo metaplasia, as I mentioned. So they may undergo squamous metaplasia, and they can appear as small squamoid islands. In various areas, you can also see ectasia. That is, you can see the ducts are dilated, and you have these insulated secretions within them, and hyperplasia of the ductal lining. You can see this showing oncocytic change. Okay, so all these changes are very common in a chronic silidinitis, and that may predispose a postgraduate especially to think that probably it could be a neoplasm. But what again I want to highlight here is the maintenance of the lobular architecture. Okay, though there are a lot of changes that have occurred in the salivary gland, architecture is still maintained. And then you have the mucocele, which is a commonly encountered lesion that most of you would have seen a mucocele. I've included it as a part of this just to complete the presentation. So on FNAC, usually you can see that there'll be a mucoid, and you have this typical pulled appearance of the cells, where the cells tend to branch out from a central area, which is the mucin. They tend to stick to it, so you have this branching appearance. This is very characteristic of any salivary gland FNAC. Usually you have this branching. Then you have these macrophages, which can be seen, which are nothing but the mucinophages. So this was a mucus extravasation cyst. So the mucus extravasation cysts, which usually occur because of trauma to the duct. And this is a mucus extravasation cyst. You can see the mucus which is pulling. It's a pseudocyst, so usually you do not have an epithelial lining. But there is a lot of organization that occurs around the pulled mucin, and it forms the granulation tissue. So you can see this granulation tissue which is formed around the mucin, and the mucin being engulfed by the mucinophages, and these are the remnants of the salivary gland which are seen at the periphery. This is a hyper view of the same. See the organization of the collagen that is seen here. There is no epithelial lining, so it's considered to be a pseudocyst. Okay, so these are your mucinophages, and this is your epithelial lining. Okay, so this is for a mucus extravasation cyst. Then you have instances where you have a lot of mucus which usually happens, but there is no organization, there is no formation of a nice cystic cavity or a cystic lumen which you can see, but there is destruction of the or disruption of the architecture in the surrounding mucosa surrounding the saliva. You can have these instances where you can see there is some amount of mucus pooling which is happening, but there is not much of an organization which has happened. There is no granulation tissue which is formed. There's no nice cavity which is seen. Okay, so that time you can see this is all mucin. You can see the mucinophages here. So in that conditions, you usually call it as a mucus extravasation phenomena rather than calling it as a cyst, because you do not have a nice cystic lumen. So a cyst usually should have a cavity, it should have a epithelium and a lining, and if it is a pseudocyst, it should have a cavity and a cyst wall. So because there is no cyst wall here, we usually use the term mucus extravasation phenomena. And then you have another type of mucocele, which is the mucus retention cyst, which usually occurs because of some obstruction in the duct, either because of silolith, or it's a tumor which is impinging on it, or because of some strictures. So what happens is the mucus that is cannot come out, so it gets pooled on the distal side of the obstruction, and then you get a cyst which is lined by the ductal epithelium. So this is your mucus retention cyst. If you see the difference with that of mucus extravasation cyst, there was no lining. Here you have a nice okay, so this is the hyper view of the ductal lining, which is showing you a pseudo-stratified ciliated lining along with the mucusels, which are highlighted by the past stain. So the mucus retention cyst occasionally may be confused with a low-grade mucoepidermoid carcinoma, especially if it is a multicystic mucocele. So this was a nice case where you had multiple cyst-like enlargements which were seen, cyst-like retention cysts which were seen replacing the salivary gland tissue, especially in the submandibular gland, and this could lead to a suspicion of a mucoepidermoid carcinoma, low-grade variant. But if you see the lining, it is predominantly made up of only low cuboidal cells. You do not have the typical intermediate cells or the mucus and the epidermoid cells which you see in the mucoepidermoid carcinoma. But it could be confused with a low-grade mucoepidermoid carcinoma. So this is a rare mucocele. The important lesion that is usually confused with carcinoma is necrotizing silometaplasia, which clinically usually most commonly seen in the palate and clinically presents as a ulceroproliferative lesion. And posterior palate is the most common site. It could be because of trauma, it could be because of ill-fitting dentures, it could be because of dental injections. So what happens here is there is secondary to all of these traumatic conditions, there is ischemia of the salivary gland which is present in the ischemia of the salivary glands which are present there, and they undergo necrosis, and that results in formation of this ulcer which is there. It is usually self-healing, but because it looks very sinister, most of the time the surgeons feel that it could be a squamous cell carcinoma, and they go in for a biopsy. And if you do a biopsy, this is how it looks. You can see that, as the name suggests, okay, if you see the name, it's necrotizing silometaplasia, process of the salivary glands, and they are undergoing metaplasia. So what you see histologically is your discontinuous epithelium. The acini have undergone destruction. You can see that the architecture is totally lost. These are your mucous acini. They have lost the architecture. They are appearing swollen. Okay, so they are undergoing liquefaction, degeneration, and then you have your ducts which are undergoing metaplasia. That is squamous metaplasia. The ducts are hyperplastic and they are undergoing squamous metaplasia. Hyper view of this acini, which are all have undergone degeneration, and these are your squamous metaplasia. And many other times, because of the squamous metaplasia, the lumen is lost and they appear like islands. And it may be confused with the squamous cell carcinoma, and also the presence of mucus and the squamous island. Many a times, histologically, it may be confused with the mucoepidermoid carcinoma also. So this is one of the reactive lesions which may be confused with mucoepidermoid carcinoma. Again, I go back to the low power, see the lobular architecture. It's maintained. Okay, so remember, architectural evaluation at low power is an important component that you need to keep in mind whenever you are evaluating the salivary gland lesions, regardless of whether it is a reactive lesion or it is a tumor. Okay, so let's see one diagnostic trap which most postgraduates usually fall into the trap. So this is a 36-year-old female patient who came with swelling in the right and left parotid glands since 6 years. And we did a biopsy, and this is what we saw. The entire salivary gland was replaced by dense lymphocytic infiltrate. And the first thing that the postgraduates usually think, and that is the diagnostic trap here, that is lymphoma. Okay, but if you go on seeing further, you can see that the lobular architecture was still maintained. There was some amount of salivary gland tissue which was also still intact, and you could see these epithelial islands. Okay, so these epithelial islands within the dense lymphocyte are nothing but the epithelial myoepithelial islands. Okay, so these are your epithelial myoepithelial. So this is a case of benign lymphoepithelial lesion. Okay, so postgraduates usually think it to be a lymphoma. Diagnosing a reactive lesion like a benign epithelial uh, lymphoepithelial lesion, you have to follow this 3-step framework regardless of whether it is a benign or malignant, and we will be catching it up subsequently when we are doing it. So first and foremost, you see for the architecture, if the lobular framework is still recognizable, there is no haphazard invasion into surrounding tissues, it actually points away from neoplasm. Of course, clinical behavior is the most important thing that you need to take into consideration. The clinical behavior, slow growing, asymptomatic, points towards benign and reactive. If it is rapid growing, if there is ulceration, if there is discontinuity, if there is facial nerve palsy, you have to think of malignancy. Apart from that, when you see the slide, the first thing that you are going to see at low power is the architecture. Then you go for the cytology. If there is no cytologic ATPI in the epithelial islands and there is a polymorphous lymphoid population along with plasma cells, you think it to be reactive. And one test that you are going to do is not required here because you have a nice morphology, you have the architecture, you may not require a CD45 to rule out lymphoma. You may have to do it only if you have a monotonous lymphoid population, if there is, or if there is clinically you have a lot of ulceration, you have multiple lymph node involvement, if you are suspecting lymphoma, then only go for a one test that could help you. So I want to highlight here the low power. You have to develop low power first thinking. Always start at the scanner view because your diagnosis begins at low power. High power comes later. High power is only to confirm the impressions. It is not to create. Okay, if you are creating impressions on high power, you are actually confusing yourself. So some common overcalls in the training, what should reassure you, what should worry you, what should reassure you if it is uniform, if there is lobulation, if there is organization, don't worry, it is either normal or reactive. If there is infiltration, if there is asymmetry, if there is destruction, you have to worry about what it could be. So how you differentiate between a reactive versus a neoplastic growth? Normal will have all of these, that is the SNI ducts intact and nice lobular architecture. Reactive may show destruction of the SNI and the duct, but the architecture is still maintained. Okay, so reactive lesions usually maintain the architecture, but if you go to the neoplasm here now, this is a benign neoplasm. You can see complete replacement of the salivary glands. The lobular architecture is completely lost, and but you can see there is some amount of circumscription, so that means it is benign. If it is invading into the surrounding tissues, you have to think of malignancy. So this is how we approach. If you have normal salivary glands, it is normal. If you have nice lobular architecture still preserved, but there is destruction of acini and ducts, it could be reactive and along with inflammatory infiltrate. If there is complete effacement of the glands and the acini, but there is circumscription, it's benign. If it is invading into the surrounding tissues, it is a malignancy. So always remember, do a low power examination, go for architectural evaluation, then go for cytology. And if it is a very small biopsy, it's always better you give a descriptive diagnosis rather than giving the specific grade. You can go in for a benign salivary gland tumor or a malignant salivary gland lesion. And if you're not very certain, just defer, don't overcall, ask for additional biopsies or tests. So this is a diagnostic algorithm which you can use to differentiate between normal, reactive, and neoplastic. So that comes to the end of my session today. The take-home message and why foundations matter is basically they set the pace for logical reasoning subsequently when you're going to diagnose your benign and malignant tumors. Normal salivary gland tissue is complex, but it is organized. Mixed patterns are biology in case of salivary gland tumors. They are not malignancy. Myoepithelial cells are the masters of disguise, and you have to look for them when you are dealing with salivary gland tumors. And low power analysis is the important aspect, regardless of whether it is salivary gland tumors or other tumors. Low power is something you need to develop that thinking of identifying tumors or the lesions in low power, and high power is only basically for confirming. So if you do a low power analysis properly, it can prevent high power disasters. Thank you. I would like to end by saying that a pathological change is only meaningful when compared with normal, and the ability to recognize disease depends entirely on the ability to recognize normal. These are my references. This is my college, the KLEVK Institute of Dental Sciences, and this is my team. Thank you.
Thank you, ma'am, for that extremely extensive and in-depth presentation, and the lucidity with which you presented this extremely complex organ is absolutely kept us all enraptured. Thank you very much. We would now like to take any questions, if there are any. You may post it on the question and answer box. And we have also posted a live poll. So for all the attendees, please do give your response. It will be beneficial to us to understand how useful the session has been for us. So please do take the poll.
How do they go about it?
Ma'am, there is a we need to go to the tools section, and there is a question posted, and they need to give their response in that. So there is a question. All right. How to differentiate between chronic sialadenitis and Sjogren syndrome?
Shall I take it?
Please, ma'am.
Okay, so chronic sialadenitis, Sjogren syndrome, to differentiate histologically, clinically, of course, there are a lot of changes which you can see in Sjogren syndrome, which is not seen in chronic sialadenitis because it is a localized lesion. Sjogren syndrome is a syndrome, so you will have a lot of changes which are seen clinically. So clinical pathologic correlation, of course, plays a very important role. Apart from that, you can see histologically the presence of epimyoepithelial islands, which are not seen in chronic sialadenitis. In chronic sialadenitis, you will find more of ductal hyperplasia. You will not have the epimyoepithelial islands, which are very characteristic of Sjogren syndrome. I hope I answered you. If you want any, actually give that.
Any other questions?
So histologically, the key point here is the epimyoepithelial islands, which are not seen in chronic sialadenitis. I already showed you the chronic sialadenitis slide. There is ductal hyperplasia, which is usually ductal hyperplasia also is not very characteristic in Sjogren syndrome. There's complete replacement of the atrophy of the acini as well as the ducts, and there is replacement with lymphocytes, and then you have these epimyoepithelial islands.
So there's another question. In which all salivary gland lesions can we see epimyoepithelial islands?
In the benign lymphoepithelial lesions, lymphoepithelial cysts, and Sjogren syndrome. And we will be covering the lymphoepithelial lesions in the benign tumors. Lymphoepithelial carcinomas, all of those will be covered in the malignant and the benign.
So I think that's all. As far as the questions are concerned, if there are any, please post them right away so that we can address them immediately. I think the session gave us an extremely comprehensive and clear overview of the histology of salivary glands along with its clinical correlation. Thank you very much, ma'am, for this extremely engaging and enlightening session.
Thank you so much for inviting me. I think it sets space for the next one, which is going to be more challenging.
Absolutely, ma'am. So thank you. Thank you so much for attending. Thank you, everybody, my teachers, students, PGs, UGs, for coming and attending this session. We hope to see you again in the second session, which is to be on the 20th of January. Please do join.
Thank you so much. Thank you. Thank you all for attending this session. Shall I leave? Or could we see the poll?
Yes, ma'am. Just a moment. So the question on the poll was, after this webinar session, how confident are you in understanding the basic histological structure of salivary gland? And almost everybody has said that they're very confident.
That's nice to know. I would request all of you to go back, open your salivary glands, which are there in your third year box, and go through them again, so revise the entire thing that we covered today, because unless for years, it's very difficult in your mind to identify them subsequently.
So we are extremely honored to also have Vanaki sir here with us. Hello, sir.
Good afternoon, sir.
Good afternoon, sir. So we would just like you to say a few words, sir. Please unmute, sir. Just 1 minute, sir. Just one moment. Sir, you may unmute yourself, please.
Yeah, I'm very sorry. I just missed. Actually, it's my, very interesting topic. I just missed. Sorry, Dr. Pune. And
No problem.
I hope, you all must have done very well. And I hope to attend at least the next one. I was stuck with some other work. Then suddenly I remembered and I joined. By then we were almost completing it. I'm sure it would have been a fantastic webinar. I'm sure I all must have refreshed most of the memories, whatever we had, isn't it? And adding some more new things to that. It's a nice topic. Actually, very difficult to diagnose salivary gland tumors, and I have got more interest to go through the complete details on the minor salivary gland tumors. They're going to be totally different than the major, and that's what I was. I had done a presentation somewhere else, and I hope to redo it again because we are getting a lot of minor salivary gland tumors, which are going to be totally
Yes.
different than what we have it in the major counterpart. So somehow I feel mine is totally different than the major ones. I hope in the next session I highlight more on that, and I love to listen to that.
Sure, sir. Thank you.
Thank you. All the best. And I'm very happy that webinar series are continuing. I hope we can also be part of one of the webinars in future. Hmm?
Thank you very much, sir, for sharing your thoughts.
Yeah, thank you.
Thank you, everyone. We may now end the meeting. Thank you so much.